Very good afternoon, everyone. It is with great honor and pleasure that I welcome you all to this 15th Pediatric TB Eco Clinic in collaboration with Regional Pediatric Center of Excellence for Tuberculosis. The Eco Clinic is a dynamic platform for case-based clinical discussion and dissemination of knowledge and bringing all experts together across the country for managing tuberculosis among children. On behalf of National Institute of Tuberculosis and Respiratory Diseases, I extend my heartfelt welcome to the directors and representatives from NIRT, NTI, state TB officers, directors of STDCs, esteemed faculty members from medical colleges, district TB officers, medical officers, pediatric TB specialists, and all healthcare professionals participating in this session. Now, please let me introduce the faculty from NITRD. I am Dr. Tulika Dhingra, Specialist Peds at NITRD, and I will be moderating today's session. With me is Dr. Sangeeta Sharma, Chief in charge of the National Center of Excellence for Pediatric TB and also former director of NITRD. To my extreme left is Dr. Alok Yadav, CMO NFSG and pediatrician at NITRD. I would now like to request Dr. Sangeeta Sharma ma'am to please address the gathering and give her opening remarks. Over to you.
Thanks, Dulika, and welcome all for joining in. We have traveled this journey together, and I'm so happy that you all logged in, sparing your valuable and precious time. This session is going to be presented by AIMS, and I'm sure you'll benefit. And please feel free to ask questions because it's a two-way learning process, and we'll be more than happy to take up all the questions and answers. Without wasting time, I'll now request Dulika to carry the proceedings further.
Thank you, ma'am. Before we start today's session, I would like to inform the audience that we will be sharing the link to the pre-test questionnaire. I would request all of you to attempt the questionnaire so that you can benefit maximum. Without any further delay, I would now like to start today's session. Today's presenting team is Department of Pediatrics, AIMS Raipur, led by Dr. Atul Jindal, Professor and Head, Department of Pediatrics, AIMS Raipur. The case presenter for today is Dr. Satvik, DM Senior Resident, and the didactic lecture would be presented by Dr. Manas, Additional Professor, Department of Pediatrics at AIMS Raipur. The national expert for today's session is Dr. Sangeeta Sharma ma'am. Over to you, team AIMS Raipur.
Thank you, madam. First of all, I would like to thank NITRD team, ECO team, and Ashok Bharadwaj sir for giving us this opportunity for discussing with you all an interesting case of TB, followed by a lecture on TB in tiny tots. So I would request Dr. Satvik to start with this presentation.
Good afternoon, Mananda. Are my slides visible?
Yes, Dr. Satvik, your slides are visible, but can you please make it into a slideshow?
Is it fine now?
Yes, yes. Please.
Yeah. Good afternoon, Mananda. Without much ado, I'll be presenting a case from AIMS Raipur. So, we'll be seeing the overall case course and what are the diagnostic modalities which we are taking to diagnose and what are the treatment difficulties which we have faced during the management. So we had baby B, 7-month-old from Raipur, who presented to us, was brought to us by her mother, and she stayed for total duration 52 days in the hospital. So she presented to us with complaints of fever for 8 days, which was undocumented and low grade, which was treated with medications, and it was associated with cough, which was again associated for 8 days. It was productive in nature, there was no diurnal variation, and it was not related to any change in posture. For last 5 days, child also had respiratory distress in form of fast breathing and chest infections. Mother also gives a complaint of not getting adequate weight for last month, though it was not quantified. And on day of illness, she was presented to us in AIMS lab. So there was no history of any nasal revisitation of feeds, any increased precordial activity, or any success subcycling, or salty kiss, or any rash, or vomiting, jaundice, or seizures. So she also had similar complaints at 2 months of age, for which she was ventilated outside for 5 days.
Just Satvik, just a second. Just
Because we have pediatricians also in this group who joined in, the district TB officers and TB specialists. So, going back to your history, can you just tell them why you took this, the history of greasy stools, salty case, etc.?
Yes, ma'am. Actually, basically, she presented to us with the similar complaints previously as well. So, we are in lines of diagnosis of persistent or recurrent pneumonia, considering early infantile period. So, we are thinking in terms of cystic fibrosis or any severe dyskinesias or any congenital heart disease which is predisposing the child to multiple episodes of greasy pneumonia. So, in those aspects, we had asked this negative history. And also nasal regurgitation of feeds and all just indicate that probably there is some dysfunction in the swallowing, which might lead to microaspirations and persistent or recurrent pneumonia. Similarly, increased precordial activity, suppressed sex cycle, all these indicate there is underlying heart disease which is predisposing them to recurrent infections. And the salty to case, greasy stools, rash and all are part of cystic fibrosis, which we are thinking, and other immunodeficiencies which might precipitate in the same fashion, that is with persistent or recurrent pneumonia. Is it okay?
Yeah.
Yeah. So as I told earlier, so the child also had similar complaints at 2 months of age, for which she was outside ventilated for 5 days. And coming to family history, the index child is one of the twins. That other sibling had expired with similar illness at 5 months of age. And maternal grandfather had history of pulmonary tuberculosis, though he was treated for 6 months before the children were born, 2 years before the children were born. And our index child was immunized up to 3.5 months of age. Coming to developmental history, there was developmental delay in the motor domain, with only head control being attained. Otherwise, in other domains, it was fairly okay. So, coming to general examination findings, child had pallor, and apart from that, there was no other significant findings on general examination. And child had tachycardia with heart rate of 175 per minute, with tachypnea of 65 per minute, other vitals being within normal limits. And on anthropometry, in all the parameters, the child was having just a month. They still with child with weight, length, head circumference, all being standard. Coming to systemic examination, so there were both subcostal as well as intercostal retractions, and there was dull note on percussion on right side with increased focal frequency. And on auscultation, ARG was decreased in right infraclavicular, supraclavicular, bilateral, with bilateral clefts being audible. And central and CVS and parabdominal examination was within normal limits. And however, on central nervous system examination, we found that child had hypotonia in all the 4 groups. So to summarize our case, we had a 7-month-old infant being one of the twin who presented with features of acute respiratory distress with failure to thrive, with developmental delay and similar illness at 2 months of age as well, and other sibling who was died with a similar history. So with this, we have kept in our mind as a group possibilities of persistent and recurrent pneumonia. So we have considered cystic fibrosis, primary ciliary dyskinesias, and immunodeficiency. Precipitate with these underlying conditions, the child was precipitated probably by some other with some infection, probably it could be bacterial or tuberculosis or any atypical organisms. So these were this was the admission X-ray. So as you can see, at 2 months of age, the X-rays displayed on the left side. In that admission, you can notice that there was definitely right upper zone in homogeneous opacity. And apart from that, there was some amount of inhomogeneous opacities on both right, middle, and lower zone, as well as on the left side as well. So, with that, on day 1 of investigations, there was anemia of HB 9.2 with leukocytosis, basically neutrophilic leukocytosis, as well as monocytosis, and platelet count was 6.7. And CRP was elevated, which was 66.7. And apart from that, in other liver function tests, there was mild transaminases. And procalcitonin was high. So, the child was admitted in the hospital. So for the respiratory distress part, she was started on HFNC support at 1.5 liter per kg per minute, and IX was started in form of 50,000 minutes. for failure to thrive part, she was started on nutritional supplements and advised to start complementary foods, and it was ensured that it was started. So we had on day one itself gastric lavage, and it turned out to be AFP negative, but however, on CPNAT it was positive with rifampicin sensitive. So for the same, on by day 4 of our hospital stay, we had started the child on for the ATT regime along with the antibiotics which was stopped because we were the organism. And for right upper lobe consolidation collapse, chest physiotherapy was continued. And the child could be made from HMNA support, and the child is shifted from people to however, in the ward onset he was. So at this juncture, we suspected either bacterial co-infection or paradoxical reaction. So we took the child back to TICU again. So in the second TICU admission, we noticed that child had worsening in the form of increased rates as well as loss of breathing. And for the respiratory support, child was shifted on non-invasive ventilation. And in suspicion of bacterial co-infection, we had started the child on mirror. On the X-ray, you can see that the right upper collapse consolidation is persisting to the sharp margin. And apart from that, the infiltrates bilaterally have worsened now with some amount of necrotization. So for these new infiltrates and new onset respiratory worsening, we had done bronchoscopy. And on the bronchoscopy, which I will be showing the images later, we identified that the child was having endobronchial tuberculosis. And on bronchoscopic alveolar lavage samples, we found that it was failure to look at grossly, and it was surveyed in appearance with leukocytosis of PM40, predominantly lymphocytic predominant. And apart from that, AFB and CBNAT turned out to be negative with bacterial culture being sterile. Because the child had evidence of endobronchial tuberculosis, at this juncture, we had started steroids as to control the inflammation. And however, within next 48 hours, respiratory distress has worsened, and child was intubated or mechanically ventilated. So the bronchoscopy which we had done showed partial occlusion of the right upper lobe bronchus, and for this aspect alone, we had considered endobronchial tuberculosis, and we started the steroids. So these are the CT images which you can see, and this is the mediastinal window, which you can see that there is diffuse involvement of the right upper zone on the axial section aspect with some amount of trailing but appearance as well as breakdown. And this is the lung window in which we can see that there is definitely right upper and middle zone involvement as well as the left side involvement as well in form of trailing but appearance. With again, as I said, there is both bilaterally necrotization picture. So the child was on invasive ventilation only, but however, after starting the child on invasive ventilation, after a week, they found that the child had new onset fever and increased ventilatory settings. Because the child had worsening in the settings as well as new onset fever spikes, and child had thick purulent secretions as well, we had suspected new onset ventilator associated pneumonia and sent a mini bowel sample in which Stylotrophmonas was grown, which was instituted to meropenem and levofloxacin, and we had given the appropriate antibiotics. And apart from that, the 4-drug regime and steroids were continued. And for the collapse consolidation part, chest physiotherapy was continued as. But however, this VAP part had settled and we could again taper down the ventilatory settings. However, when we tried to extubate the child, there were numerous extubation failures in the 4th week of illness. And we had done the bronchoscopy again, and it was arrest of upper airway edema. And apart from that, the child also had hypotonia. So we got the tracheostomy done for this child, and in view of recurrent extubation failures by 3 mm cuff tube, and tuberculosis drugs were continued. And the child was on minimal TPS oxygen support, and respiratory support was continued. So we thought, okay, fine, we dealt with all the complications, and then we were fairly okay in weaning off the support. But however, in the next week, around day 35 of illness, child had new onset lymphadenopathy in the pretracheal and axillary areas, and we had sent the aspirate of that, which again showed AFP positivity with CPNAT showing rifampicin sensitivity. And again, 4-drug APT and steroids were continued. But however, the pretracheal lymph node actually turned out into abscess, which was compressing the trachea. So because the abscess was compressing the trachea and was worsening the respiratory distress, at this juncture we intervened in form of draining. So this is a representative image of a pretracheal abscess. So we had drained the pretracheal abscess because the child had respiratory distress, and we had sent the samples of abscess with the pus, and in that AFD was positive and NG culture however was negative. So again, further ATT regime and steroids were continued. So by day 50, we could wean off the oxygen support, and we plan to decandidate in follow-up, and steroids were given for 4 weeks and tapered off in the next 2 weeks. And 4-drug ATT was given for a total of 2 months, and plan to switch to 3-drug ATT. So coming to the review of case, so in our case, we had pulmonary tuberculosis with consolidation, cavitation, and endobronchial. Not sure about biliary TB. On chest X-ray, it was looking like biliary TB, but on chest X-ray, but on CCT chest, it was more of strain but appearance. And apart from that, the child had multiple extubation failures requiring tracheostomy and required persistent oxygen requirement for almost 50 days of hospitalizations, and we could slowly taper it off. And apart from that, during the intubation period, the child also reduced treatment performance. But now the main gist of our case was on ATT, the child had developed new onset lymphadenopathy, which on drainage found to be having acid-fast vessel segments. So this we are attributed to paradoxical reaction. So as we all know, TB, immune reconstitution, immunity have a hand-in-hand role in leading to inflammatory reaction. So whenever we have decreased immunity, the bacteria will be overgrown. But when the immunity is taking over the bacteria, then infection will be contained. But however, due to the hyperinflammatory state, there will be more organ damage. So the immune reconstitution inflammatory syndrome is as old as 1950. It was first time described in as old as 1954. And so it's basically described as new or worsening pulmonary infiltrates, typically appear 2 to 4 weeks after starting the ATT. And usually it is pulmonary infiltrate, but apart from that, it can be extrapulmonary involvement as well, just like how we had in our case. So in our case, it was new or enlarging lymphadenopathy. And apart from that, they can be tuberculomas as well, that is CNS new onset lesions as well. And usually they will be after 3 months after starting the CNS tuberculosis treatment. This is because for the first 2 months, usually we give steroids along with the ATT in case of CNS tuberculosis. So when we are weaning off the steroids, that time itself, they present us with immune reconstitution syndrome. So TB iris can be of 2 types, that is either unmasking or paradoxical reaction. So in unmasking, there was some subclinical disease which has now progressed to clinical disease when the immunity has improved. Whereas in paradoxical reaction, it is progression or appearance of new clinical findings in those who are already recognized to have clinical tuberculosis and were started on treatment. So classically, it was described in immune deficient patients, like that is HIV patients, but can be also seen in any other immunosuppressants during the time of withdrawal. So for this, we usually tackle the immune reconstitution syndrome by using steroids only. We usually give for 2 weeks followed by tapering. And in few cases, we even tried NSAIDs, thalidomide, and other immunosuppressants. The most important part is if the child is having HIV co-infection, we should never discontinue the ART treatment while hitting the paradoxical reactions. So usually we get confused between reinfection and paradoxical reaction. Well, paradoxical reaction is something which happens during the ongoing treatment. Reinfection is something which is due to new infection with different strain after the cure of clinical tuberculosis. And in reinfection happens in children who are having poor immunity, whereas paradoxical reaction happens due to exaggerated immune response. So many of you might be wondering why there was near positivity in our case from lymph node drainage at around almost 5 weeks into the treatment of ATT. So it is well known that when in paradoxical reaction, there might be smear positivity because smear is basically staining the cell wall fragments. So it may not, smear positivity doesn't always equate to viable bacilli. Smear positivity doesn't mean always it should be CD4 positive. So cell wall is stained, which may be because of remnants, and these remnants actually trigger the paradoxical reaction. And it's a well-known entity in the paradoxical reaction. So I would like to end my talk by summarizing the case again, that we had a 7-month-old infant who presented to us with acute history of respiratory illness with, however, significant past history with similar complaints at 2 months of age, and other twin basically who are expired at 5 months of age with the similar illness. And during the course of pulmonary tuberculosis treatment, the child developed complications in form of cavitation as well as endobronchial involvement. And apart from that, had also features of paradoxical reaction with pretracheal lymph node, which later turned out to be abscess. And for the respiratory components, we had to drain the abscess. And further, she was weaned off the support within day 50 of hospitals. Thank you.
Thank you, Satvik. I think the HIV was also done, and we
Yes, sir.
also
Yes, sir. Actually,
deficiency.
yeah, other immunodeficiency workup was also done, and it was negative. So retro was also negative, and other lymphocyte subset and immunoglobulin was within normal. And we were also screened for other organ involvement in case because it was an infant for dissemination. And CSF was done, which was normal, and even ultrasound abdominal screening was within normal.
Thank you, sir.
Thank you. Thank you, Dr. Satvik. I would now invite questions from the audience if they have any doubts. Dr. Ajay is asking if the patient had SAM. I think they had mentioned in the initial slides that the weight was less minus PST. If
Yes, ma'am.
There is a question on experience with thalidomide. Sir, we don't have any experience with thalidomide. We have never used thalidomide for paradoxical reactions. Generally, they would settle down with just usage of steroids in 1 to 2 mg per kg per dose. And generally, most of them would settle down. So I am yet to see a paradoxical reaction requiring therapy beyond steroids. Maybe other experts can share their experience on it.
Atul.
Yes, sir.
So I want to know whether this patient landed to your institution or this patient was shown to some other health facility before he or she landed in your institution.
Sir, this patient was referred to us from another hospital.
Okay. So they had started some treatment or not?
So the child was on some antibiotics, but then patient came to us in emergency, and then he was admitted subsequently on in the PICU because child was in frank respiratory distress and possibly in respiratory failure as well.
So all investigations were done by you, not by the previous institute.
Previous hospital had some basic CBC and maybe electrolytes.
Basic electric, sir. Yes, sir.
Not for TB, not for TB.
Not for tuberculosis, sir. Not for
Okay,
tuberculosis. Child was actually referred for persistent oblique recurrent pneumonia for workup. So that's why this child ended up with us.
Okay, thank you. Thank you, Atul. Thank you.
Dr. Satvik, very nicely presented the case. I have only one two questions regarding at the age of 2 months when the child was admitted in hospital, and I think at that time child is also invasive ventilation support was given at the time of 2 months of the age. Is there any TB workup was done at that time or not?
No, sir. That was actually the first presentation. So at that point, they hadn't suspected the tuberculosis. It was only for 5 days. The child was ventilated only for 5 days, and then it was weaned off the support within the next 2 3 days.
What are the cause at that time? Some reports or some previously reports shows anything? Is that time pneumonia or something other?
Actually, we didn't have the documents, but parents were telling that the child was told to be having community acquired pneumonia, for which the child was requiring invasive ventilation.
Okay, good. And one thing I just want to know, okay, is there any line probe as a LPA report was sent to find out the first line INH resistance in this case or not? Initially, as you told that in the GA the child was found positive, and in one of the sample of the abscess this child is found positive in the AFB and gastric and CNAT sample. So any line probe assay or any culture which was so some other resistance also, because as primarily we are treating this child as a drug sensitive TB. So just any other to clear this child is have some additive resistance or not. So any report awaiting or any report was within you?
Yes, so actually the rifampicin sensitivity was noted on the CBNAT samples, both in lymph node as well as in the GL. And MZ culture was sterile in all the samples which we have seen, sir.
Any LP reports?
No, sir, actually, we suspect, matlab, we didn't actually be treated in lines of drugs instead of TB only.
But actually, first line LP is also can do to rule out the INH resistance. Just and the as you told that
the smear is negative, no?
gastric aspirate.
Gastric
For the culture.
He says culture is negative.
No.
Culture was negative, initial culture.
Yes, sir. Yes, ma'am. Culture was sterile. CBNAT was showing MTB with rifampicin instrument.
So all the cultures done till date, they are negative.
Yes.
GAT, yes?
Yes, ma'am.
Okay.
And what about blood sugar and HIV?
Later workup was negative, ma'am, and sugars were within normal.
That is very important, when you are discussing deterioration.
Yes, ma'am.
The other thing is, this case has a short history of 8 days. So, we have to rule out whenever there is deterioration on ATT, the first thing which we say, always get a blood sugar as well as rule out HIV. So,
Yes, ma'am.
they are negative in your case?
Yes, ma'am. It was negative. Later was negative, ma'am. And sugars were within normal.
Okay.
Sangeeta,
Yes, sir.
is there what about the reverse family screening in this patient?
Yeah, this is what I wanted to say because one of the siblings died because of tuberculosis, and there is a history of maternal grandfather who had TB before the child was born.
Yes,
That does not.
What about the rest of the family members?
Yes, this is what I want to say. You need to get family screening done. That there is something in the family which is leading on to, tuberculosis in two small infants who are not subjected to the outside world. So please get an extended family screen done for tuberculosis. That is, reverse contact tracing.
Okay.
Sangeeta,
What is the
still we
reason
are
for
lacking
the
in the
different
TB
periods?
prevention.
Sir, that is once they screen the family
Yes, yes,
and they decide that, the family, maybe there is some active case in the family which is undetected. And now,
yes,
as he has highlighted this clinical entity which is emerging called asymptomatic tuberculosis. There could be a adult in the family who does not have any symptoms, but it could be culture positive, and
yes,
that would
yes,
be the source because two
yes, yes.
young infants in the same family having tuberculosis. So please address this and depending upon their status, then obviously as the issue has risen up, depending upon whether anybody has tuberculosis, start ATT or TT, depending upon the status, whether it is TB infection or TB disease. And even for asymptomatic tuberculosis, so for each adult in the family, please do get a sputum test done and send a sample for NAT as well as for liquid culture.
Ma'am, since Dr. Jindal is also the state task force chairman of Chhattisgarh, so I'll humbly request him to please do something for this TB prevention and screening of family contacts, household family contacts. So, I hope Dr. Jindal, you will, hearing me, and you will do something for this purpose.
Sir, just to answer these questions in the comments, the extensive reverse family screening was done for both the maternal and the paternal side. Just because that's why that was the point for mentioning that the sibling died with the similar illness, and there was a history of tuberculosis in the family, and the grandfather completed the treatment despite before the birth of the babies. Despite that, we assume that there might be someone living in the family which was the source of the source for the tuberculosis to be spread to these two small kids. And there were all risk factors for these babies because these babies were severely acute malnourished. We don't know about the sibling who died. But this child was severely malnourished and also possibly had failure to thrive, maybe because of the illness which was there since the 2 months of life. But we definitely did the reverse screening and which was negative, sir. And thank you for the comment, sir. We will definitely try our best to educate other pediatricians and the DTOs in our state for the same. Thank you, sir.
Thank you.
And
Thank you.
even
Thank you, sir. Thank you.
say even if there is any question comes to the family, because I've seen sometimes the source is not in the family, but the house help or the maid who is coming and going, she might be the so please get that aspect also ruled out, because there is some focus which is going undetected around these children.
So we have to look for the extended family now. It's very clear.
Exactly.
It may be even a visitor once in a while who is visiting their house. And as Dr. Sangeeta, you rightly point out, we have to look for asymptomatic TB, who is going to probably be responsible here.
Point well taken, sir. Point
Yeah.
well taken. Thank you, sir.
And
Hello.
Dr. Atul, one more suggestion. Kindly be the font size should be large enough to be readable. So those slides were very good, but
Thank
font
you, sir.
size was very small.
Thank you, sir. Thank you for
Yeah.
the comment. We will take
Yeah.
care of it. Thank you.
So
Hello.
Dr. Jayakishan has a question.
So I would like to say that the childhood tuberculosis, one, in the primary stage, there is a lymphatic nodal component which is prominent. In progressive primary, there may be lymph nodes also and the parenchymal component. However, there can be the adult tuberculosis where there is a parenchymal component only. So in this patient, whether there was lymph nodal component also not, one. Two, the patient was having the endobronchial tuberculosis. But what was the cause for the narrowing of the bronchus, whether it was the cicatrization fibrosis or extraluminal compression by the lymph nodes. And the lymph nodes, once they are extra luminal, they can also cause decompression, they can also cause the collapse. And so that can be one of the causes for the RS type of the problem, that you may have the radiological worsening because of the collapse, because of the extraluminal compression. There may be a dyspnea because the patient's lung is collapsed. Okay. And for the management point of view, once you are going for the assisted ventilation, there may not be the check well type of the mechanism, which can, the air may be entering but not going out because of the compression by the lymph nodes. So we have to take care of all these things. And what about this actual endobronchial lesion? Will you like to describe whether it was compression only, whether there was the fibrosis, whether there was ulceration, or what? One. Two, there was a compression of the pretracheal lymph nodes, a gland also, and the abscess formation also. So the possibility of the extraluminal compression of the right main bronchus cannot be ruled out. So I will like to say, ask the lymph node part, whether it was there or not, one. Two, and the description of the endobronchial tuberculosis, and then management thereof.
Yes, sir. So actually, there were no lymph nodes at the time of presentation. And coming to the endobronchial part, it was a luminal obstruction. It was not cicatrizing, it was rather just a granuloma which was obstructing the lumen of the bronchus. And these pretracheal lymph nodes were developed during the course of the treatment, that is after almost 4 to 5 weeks of treatment with the ATDs. And we had started steroids for the endobronchial tuberculosis to relieve this luminal obstruction part and relieve the collapse.
Okay. So once there is a compression only, the steroids may not help. Sometimes simple doing the bronchoscopy, which can dislodge the gland, can help in this relieving of the obstruction. Okay. So
Yes.
while doing the bronchoscopy, whether you will be able to find the external compression or not, you should note down that also. Thank you.
Dr. Sangeeta, I have one more question. Because we understand that endobronchial TB is extension of the primary complex. But probably the child became not child, infant became symptomatic, say around 1.5 to 2 months. So is it difficult to label a diagnosis of endobronchial tuberculosis? Now there are isolated case reports are there in the literature. So what made the diagnosis of endobronchial tuberculosis in this patient?
Sir, sir, because when we did the bronchoscopy, we could see a lot of caseous necrosis in the bronchial endothelium, and there was a lot of edema. So that was clear-cut demonstrative of endobronchial TB, sir. And we couldn't see any, external dents on the tracheal margin. So tracheal margin inside lumen was smooth, except for there was a lot of edema, and we could see clear-cut caseous necrosis. In fact, Satvik showed some images. Unfortunately, we had not recorded. We couldn't find the recorded video of this child. But we could have shown it was very classical, caseous necrosis seen in the endothelium with whitish dirty patch lining the trachea, sir. And the lymph node involvement was not there clinically as well as radiologically in the initial presentation. It was only during the paradoxical reaction we could see that there was a pretracheal abscess, and then it was definitely, sir, that abscess was compressing on the trachea and causing worsening of the respiratory distress, which was requiring drainage of that abscess. So you made a very valid point that it could be both. Lymph nodes can be involved both in the primary progressive disease as well as they can be a part of the paradoxical reactions.
Thank you, Atul.
Thank you, sir.
If there are no more questions, we can go ahead with the didactic lecture. Any more questions for now? Okay, I think Dr. Manas, we can proceed with the didactic lecture now.
Thank you, madam. Good afternoon, one and all. So I think the discussion regarding the previous case has set the background for my lecture nicely. So thank you, Dr. Satvik, for a nice presentation. Actually, he has told the story of the one child who had a lot of difficulties, more hospital stay, a lot of complications, and subsequently recovered with a successful outcome. So I am going to tell the other side of the story, what is really the community. Not heard, not heard. So this is regarding TB host big. So there is under children and how to prevent the TB in most vulnerable. So my objectives will be, so really this under 5 children, they are staying in home. So whether really their burden of the tuberculosis is how much? Is it significant for the community perspective? If at all, how much? And next question is why they are vulnerable. Though everybody knows, I will slightly deal with the basics and what could be done, like identify key strategies for prevention in early childhood. So with these 3 objectives, I will move forward. So if you see, look at the data, magnitude of the problems in India, total global TB burden. So this India contributes to almost 28% of global burden of TB in children up to 14 years. If you see, whatever childhood tuberculosis is there, 50% is contributed by under 5 children. And the peculiarity is the detection gap is 56 to 60%. Means out of maybe 2 children, we are not able to detect 1 case. Third thing is untreated under 5 children have mortality nearly 43, that is roughly you can say 50% versus treated group. So means there is scope, broad intervention, early detection can have good intervention for their survival. And just going back to the basics, natural history. So TB is a disease as disease. There will be exposure, susceptible individual who are exposed to a microbiological positive pulmonary tuberculosis. When somebody coughs, that tubercle basically comes in and aerosol forms, and that is inhaled by the susceptible person or child. If that tubercle basically is bored inside the lungs and sits in the alveolar microphase, we call it infection. When it manifests clinically, symptoms like fever, respiratory problems, weight loss, subtle symptoms to more symptoms, we call it disease. So just this is natural history of tuberculosis on the left side. So after exposure is an adult case. Clearance of infection due to cell-mediated immunity, almost 70%. So 30% they are infected in adult. Out of that, 10% due to less immunity, they go to primary progressive TB, and 90% of whatever primary infection, they remain silent, like latent tuberculosis. Upon reactivation, they may present post-viral tuberculosis and sometimes remain latent. So in this, so what are the two forms of the disease? So whenever susceptible individual inhales the microbiome tuberculosis, that bacteria goes and sits in the untrained or unactivated macrophage in the alveoli, which state we call it disease. Depending on the balance of the immunity and host immunity and virulence. So if it is not able to clear completely in the left side, like bacteria is not able to grow, but cell-mediated immunity cannot completely suppress. So there will be balance and it will lead to latent tubercular infection. If immunity is low, others tilts towards the opposite side. So there is active tuberculosis in the patient. So next question is, what are the risk of infection from exposure in under 5 children? If you see here, so risk of infection after household exposure means a close contact who stays night. So in those situations, 30 to 50% versus adult 20%. So 1.5 to 2 times more risk of getting infection after being exposed to. So second question lies, if after infection, what is the chance of getting disease in children? So if you see also, below 1 year, more the younger infants. So there is whatever chance of infection. So there is 30 to 40% pulmonary and 10 to 20% disseminated TB or TB meningitis. So more pulmonary TB as well as more progression of the lesion. Third question is, how rapidly they become symptomatic. Under 5 children progress to disease within 6 to 9 months. Compared to adult throughout their lifespan with risk of tuberculosis around 20%. Much more risk in the initial 2 years, but compared to adult, in children, they progress very fast. So we have to be proactive. So till now, what we understand the peculiarity of this under 5 childhood tuberculosis, it contributes 50% of childhood, major chunk. Once exposed, risk of infection is 50%. Progression of disease from infection, that is 50%. Progression of disease within very rapidly 6 to 9 months, and if not treated, death also like 43%. So this shows how gravity of the situation, and detection rate is also 50%. So much more child contributes, they are undetected, more progression and more vulnerable, having bad outcome. So the question is why? So peculiarity of TB infection is, here the immunity does not cross from the mother to the baby. Like some infections, if mother is infected, she has immunity, then that crosses the placenta because antibody mediated. This is cell mediated immunity. So depending on the balance between immunity and virulence of the tuberculosis. First picture is like that here. So this terrorist-like picture is the microbial tuberculosis. If they are strong enough, they will kill the immunity and there will be primary progressive TB. Second thing, clearance. If our immunity is strong enough, they will be clearing the tuberculosis. This is the second scenario. Third scenario, much more prevalent in the adult, that is, it is not enough to suppress, but completely clear. Tubercular bacillus is not cleared properly, it stays in the body. It looks for the opportunity. Whenever cell immunity goes down, it manifests disease. So just like the sleeper cell, you cannot detect them. So they are as harmful as the dangerous TB, but they remain in very silent phase, which is very difficult to detect. Third thing is, in adolescent and adults, sometimes cell immunity is good enough, but it has also its own side effects. We call it collateral damage. That is tissue hypersensitive to reaction. To localize the pathology, to prevent the spread, there will be gaseous necrosis, all those formation by the type 4 hypersensitive reaction. But if that is disproportionately more, that will cause more local tissue damage forming capital lesions. So this clearly shows different presentation of tuberculosis according to our immunity level. And when immunity is concerned, if you go, children are not many adults. We know, everybody knows. Another one thing I want to add, infants are not also many children. So here you can see here. So how our body handles the tuberculosis differently by the infants. So whenever organism comes, so it goes to the untrained macrophage. Macrophage has the role, which is a part of our innate immune system. It will stimulate or signal the T cell, which is a part of adaptive immunity, to clear the organism. But here there is two pathways. Either it is a pro-inflammatory pathway or it is an anti-inflammatory pathway. Surprisingly, in infants, the pathways go more towards anti-inflammatory pathway. That clearly says that they are more vulnerable for infection because of there is less, they have less scope to localize the disease. More progression of disease could be explained by this compared to older children. So now third question, what I'm going to answer. So what are the prevention strategies? So because it is remain highly silent disease unless we go from proactively, it is very difficult to tackle under 5 children tuberculosis. So it starts from the beginning. So joining starts before exposure means when the child is not being exposed to the tubercle bacillus. So obviously that is national immunization programs are there. So that is taken care by the BCG vaccination. Next question, after exposure, what we should do? Contact screening and TB tuberculosis preventive therapy. This is very crucial. I am going to highlight on this topic. Next few slides. After infection, obviously early diagnosis and proper referral so that treatment should be initiated and complication can be dealt. Last fourth one, limiting exposure. Throughout every case, you can limit the exposure. So by adopting proper TB infection control, so it will be successful. Each step, whatever lies, that is nutritional support, which makes difference in outcome as well as incidence of disease. So BCG vaccination, though it's beneficial but not sufficient. It has a good protection against disseminated, but it doesn't protect against the coronary TB. So mandatorily all neonates and up to infancy to be vaccinated, exception of symptomatic HIV and active TB disease. Contact screening. So this is important. When to be screened should be done. If a case, index case is sputum smear positive pulmonary TB, or it is proven or suspected MDR TB. Third, person living with HIV. Fourth, like our case, whenever child under 5 children comes to with disease that shows disease activities there in the community and reverse contact tracing, what already highlighted by senior our senior faculty members. So that highlight. So we should always reverse contact tracing and it has to be emphasized. So when to start tuberculosis preventive therapy? Asymptomatic child below 5 years, if they have close household contact with drug sensitive tuberculosis, pulmonary TB positive, screen the child to exclude disease and start tuberculosis preventive therapy with ISODJ. If symptomatic child, exclude active disease, then start preventive treatment. More than 5 and above, rule out active TB, then try to see whether tuberculosis infection is present or not by doing TST, the tuberculosis skin test, or AGRAT, whatever recommended. Even though this facility is not there, you can still go ahead with TB preventive therapy. Third, like those immunosuppressed case, actively we should look for the TB infection, and if it's there, we should give prophylaxis preventive therapy. Child born to mother with tuberculosis pregnancy, BCG vaccination and tuberculosis preventive therapy to be given. Absolute contraction is the active disease, relative is hepatotoxicity and acute and chronic liver disease. So re-emphasizing this, any child under 5 with exposed household contact with a pulmonary tuberculosis, spear positive or the cigarette positive, you should rule out active TB disease then and offer tubercular prevention therapy. That is isoniazid 10 mg per kg per day, maximum 300 mg below 10 years, and above 10 years 5 mg per kg per day should be given for 6 months. Neonates born to mother with active TB, so rule out active congenital TB, give isoniazid prophylaxis therapy 10 mg per kg per day for 6 months with pyridoxine 5 to 10 mg per day for 6 months. Here, one thing, BCG has to be given to all, even on isoniazid prevention prophylaxis prevention therapy. And separation from mother is not required at all. Exposed to MDR TB, you should not give this tuberculosis prevention therapy. That needs a separate discussion plan. How much effective? Various studies show that tuberculosis prevention therapy reduces 80% of chance of getting active TB. How much duration it can protect? 5 to 10 years. Next, early diagnosis and treatment already discussed. We should always try to establish the diagnosis based on the clinical suspicion, radiological investigation, and obviously we'll try our sincere effort to go for the microbiological test. Thereafter, still not there, then we should go for clinical radiological TB treatment. But empiric treatment to be avoided. We should keep other differentials and should honestly go to rule out other causes. Limiting exposure, so that remains holds true for the every space. So we have to identify the tuberculosis patients. They have to isolate it and to reduce the concentration of airborne bacilli whenever patient getting admitted. So they should be in the negative pressure rooms, or at possible they should be isolated in different rooms. And those individuals who are working healthcare facility, they should use respirators N95 mask, and the patients should be wearing the normal surgical mask. And minimum distance should be avoided, like 3 feet distance should be maintained. Malnutrition is a major, it is throughout the term. It increases the risk of tuberculosis as well as increases the modifying the outcome, means it goes negatively affects the outcome. So moderate to severe malnutrition, as described, it increases the mortality it increases the development of disease after exposure 2 to 4 times. So always has to be taken care of. To conclude, so underfed children, they are vulnerable for this TB infection. They progress more rapidly and mortality also is high. Because of untrained macrophage and weak cellular immunity and anti-inflammatory predominance, the more vulnerability is there. Prevention requires multi-pronged approach, BCG vaccination, and most probably what is not done up to mark, that is contact screening, that needs more emphasis with tuberculosis prevention therapy and nutritional support. Community has a major role to break the transmission in the chain. Hope I have cleared my 3 questions. So thank you. So now open for discussion. If any suggestion or queries can ask.
Thank you, Dr. Manas. This was indeed a very lucid presentation, especially elucidating the points with regard to TB in under 5 children, why they are a threat, and also you raised important points with regard to tuberculosis preventive therapy. This is one part that is ignored most often. So we should be actively looking for TB in case when children come to us. We should look for TB in the family and offer TPT whenever they are eligible for the same. If there are any questions from the house?
There is one question. Dr. Manas, can you elaborate regarding the active TB in mother? There is one question. Active TB in mother.
Yes.
I told.
So question, what is the question? Is
Active tuberculosis in the mother in the case.
Okay. So whenever actually a child under 5 children, if they're exposed to active TB disease in the mother, as quickly as possible, we have to rule out the infection in the child. Subsequently, without doing first rule out the active disease in the child, like clinically is that hydrochloride, fever, unrepeated cough, or those symptoms, failure to thrive or weight loss. If that is not there, they will go for X-ray and try to evaluate by gastric aspirate for the tuberculosis bacilli and CBNAT. If disease is not there, active disease is not there in child, it has to be undergone tuberculosis prevention therapy with isoniazid.
Dr. Manas, that is not the point. Point is, when will you label active tuberculosis in the mother when she has got a baby with her? What does that mean? And how long you are going to take it as active TB in a mother?
Okay, means mother active TB. Mother have a symptomatic mother, mother may be having fever. Like that criteria is similar to the adult criteria. Like whether it is a persistent fever for 2 weeks or unremittent cough or night sweats, all those symptoms, or maybe.
That symptom is for when you are going to look for a diagnosis. You use the word as active tuberculosis in the mother. What does that mean?
Active tuberculosis means if the mother is having pulmonary tuberculosis and sputum positive, that means CBNAT positive, then only those babies which are exposed to those mothers should be offered tuberculosis prevention therapy.
What about if the mother's sputum is not positive then?
Actually, this is according to NTP. It is not like they have programmatic point of view. They have referred to only those who have been exposed to microbiological positive pulmonary tuberculosis. Till now, this is 2021.
No. Madam will come to your rescue. But suppose it is a EPTV diagnosed during the 6 months of gestation. How will you manage?
Sir, as long as the symptoms are there, we should consider this patient as to be in active tuberculosis.
Let's clarify term tuberculosis from where it generated. Active tuberculosis, history of contact, active tuberculosis in last 2 years. So this is what is in the NTP guidelines. So active tuberculosis, as he has said, we include all sputum positive, all sputum negative, and even extrapulmonary TB. But the sputum positive, it's understood, because obviously, if the patient is expectorating live bacilli, that is the reason we say that during treatment, at the start of the treatment, any household contact or contact should have wear a face mask and for at least 15 to 20 days, and also have airway infection control and proper disposal of the sputum. Because by the time 15 to 20 days in a drug sensitive case, the sputum it's believed to get negative. But that is all based on the individual response. I would say it is always infections could vary case to case. Now, coming to sputum negative, is it still active tuberculosis? The answer is yes, because we are not doing daily sputum examination. Maybe today, in my case, I get the sputum done and it shows sputum negative, but it may be intermittent excretor. And coming to the extrapulmonary TB may have unidentified pulmonary involvement. So that is the reason, initially in the guidelines we had kept that active tuberculosis last 2 years, but because there is difficulty in understanding now, presently what we take is at that risk wise, that the risk is greatest when you have sputum positivity, followed by sputum negative, followed by extrapulmonary tuberculosis, and it is all case to case basis. And coming to the question of, the small child that is congenital, I would like regarding congenital tuberculosis, because now the child can have the newborn can have tuberculosis. So newborn can have tuberculosis intranatally, that is during pregnancy, because the if it is a diseased placenta and the placental barrier is not competent enough, the AFB bacilli, as happens with the other torch infections, it can reach the newborn. And in this case, because it is a blood spread, so the picture would be something like biliary tuberculosis. So also uh, there may be tubercles in the placenta, which can, it can rupture intranatally, and this child can aspirate intranatally, and it can have local lung infection. Hematological, the first primary focus will be in the liver. So, always that is the reason whenever we are suspecting intranatal spread, we always get an ultrasound abdomen done to rule out the focus in the liver. Then during labor, the child may aspirate infected secretions out of the infected blood, and that is something what we have like the postnatal infection. After that, also it mimics like it will develop as a primary focus in the lung, followed by we have already discussed the primary focus because this is a newborn child. So it can spread locally, it can spread endobronchial, it can also spread hematological and lead to the miliary spread. So that is how the congenital tuberculosis or the postnatal tuberculosis they need to be differentiated. In congenital tuberculosis, the primary focus would be in the liver, and the lung will have a miliary pattern, while the postnatal infection would present like something what we look at the Gohan's focus and its further spread. So I think that is one thing which I wanted to make it clear. Now coming to the mother is suffering from tuberculosis always, as has been highlighted, we need to give BCG vaccination because there is ample evidence that BCG prevents dissemination and dangerous forms of the disease. Initially, the word was that the primary infection uh, is not that what is protected by BCG. But now the recent most meta-analysis has shown that even it prevents primary infection by the tune of 17%. Although initially it was 0.8 to 1%, but now the recent meta-analysis has shown that even it has some role in the primary infection prevention. Whatever it is, BCG immunity, it wanes off in 10 to 15 years. So that thing we need to keep in mind. Now we need to also continue breastfeeding, but the mother should definitely wear a face mask. This is very important and proper disposal of the sputum. And airway infection control. Whenever she's feeding the child, there should be, proper air ventilation in that room, and she should properly dispose her sputum. Now, the other question which is emerging is regarding, prophylaxis for MDR-TB. So
Dr.
now,
Sangeeta, I would like to interrupt here.
yeah,
You said the active tuberculosis for 2 years. I don't understand that. Active tuberculosis when a person is symptomatic and is able to infect others. Latent is patient is asymptomatic and non-infectious. That is the difference. But why you are taking the tenure as up to 2 years?
because the risk of infection,
That is contact. Contact, we definitely take history of contact for 2 years. But active TB for 2 years, I don't think a person is going to have active tuberculosis for 2 years.
history of contact with active tuberculosis in last 2 years. I think you misunderstood. What you are saying, this is what I precisely said. So now coming to India tuberculosis, we have 6 months of levoflox to be given for MDR-TB and RR-TB contacts. Now this levoflox, and if it is resistance to levo, then you can even give moxiflox. So that is allowed under the program. But otherwise, pre-XDR and XDR-TB, there is no prophylaxis which is available not only in our country but worldwide also. That is one thing, and we also need to give pyridoxine supplementation, and now we are also giving nutritional support to even household contacts.
There is one more question regarding the CY TB intradermal test. Is this recommended right now in the pediatric TB?
Yeah, now the CYTB skin test is, we have three tests to diagnose TB infection. One is the MONTU, that is, we all know the PPD test. So the Montu uses PPD RT23 with 80 as the to prevent sticking of PPD RT23. Since PPD RT23 is not available, we have been using the PPD RT23 equivalent. And majority of the studies which are conducted, they are on 1 TU. Now 1 TU is not available, so any strength 5 TU or less, that is 1 to 5 TU is acceptable. But as PPD-RT23 deficit is there globally now, including in our country, then came the IGRA. So the IGRA, the advantages of IGRA is that it is based on the interferon gamma release assay. That is, whenever we collect the patient's blood is collected and it is exposed to two antigens of the MTB, that is ESAT6 and CFP10. So depending upon the response, the WBC they will release the interferon gamma, and that is read by the instrument. This is a very sensitive test. It depends upon the sample collection, the sample transportation, the loading, as well as reading by the equipment. They can be false negative. But the advantages of IGRA over Montu because of these two antigens is AT6 and CFP10. They do not have any cross reactivity with the BCG, neither BCG nor MOT. Because BCG and MOT, the Montu will not be able to differentiate. That is, you can have Montu positive because of BCG or MOT infection, but IGRA, that is either tube based, that is the quantiferon gold, or the slide based, that is TB spot test. The advantage is that they are specific to MTB. Now, the disadvantage I have already said that it is false negative chances. One is that disadvantage, the other disadvantage is that it is very expensive. So that led to the emergence of this new test that is called the CYTB skin test. Now, the two antigens which initially it started was one was in Copenhagen. That time it was called CTB skin test. And the other, the same antigen that is ESAT6 and CFP10 was manufactured in Russia that was called the dia skin test. So presently, this test is being manufactured in our own country by the Serum Institute of India. That is the reason Cyrus, because Cyrus Poonawala happens to be the father of the owner. So he changed the name to CY. That is, CY means Cyrus TB skin test. And it uses the ESAT6 and the CFP10. The method is exactly the same as what you are doing with two. That is, you take 0.1 ml. I do not know exactly how much antigen gets injected, but 0.1 ml of the CYTB is injected intradermally, and the reading is done after 48 to 72 hours. The only difference between Montu and this is that the cutoff. Cutoff over here is 5. It is 5 millimeter and not 10 as we are used to with the Montu test. Otherwise, so the advantages of CY, it has got all the advantages, advantages of the IGRA plus minus the disadvantages of the Montu test. So there will be no cross reactivity with BCG or with the mort of the tubercular mycobacteria. And the other, the biggest advantage is that the false negative, which I discussed with the IGRA, because they are not over here, because IGRA is a very very sensitive test. Because it is based on the WBC, their exposure to the MTB antigen. So if during the process of transportation, The WBC, they die because the WBC, the neutrophils, they have a very short lifespan. So that disadvantage is also minused once we are using the CYTB skin test. I think I've made things clear. That is what it is.
Yes, ma'am.
Any other questions from the audience?
Dr. Sangeeta, probably the question was its use in pediatrics. So as we discussed in that meeting, still it is, though DCGI says can be used in all ages, but ICMR, as we all understand, is only allows it is used beyond 18 years. So probably that was the question. Yeah.
Otherwise, DCGI has approved to be used for all ages in our country. But still, we are waiting for, the approval. The
So can I come out?
Yes, sir.
Dr. Jackson? Yes. So I have to make points that the BCG adenitis is not uncommon entity in children, and you should be thinking of that after that BCG. And there may be locally and also, and there may be the lymph nodes in the axilla also, and we should be just treating it with the macrolides or even INH, that will be sufficient. Although we should try to rule out the active TB. Okay. Then what about the role of the BCG as a test? Since there is a PSI-TB, we are not using, the quantiferon is not available, and child was not vaccinated in the early childhood. So BCG test, will it be effective in prevention also and the diagnosis of the your latent TB? Then third, say most of the time the pediatricians are blamed that they are underdiagnosing the TB in children. But one of the indication of the effectiveness of the program is that the incidence of the TB in children will decrease. So whether this is because of this the effectiveness of the program, that we are not getting the cases of the pediatric TB to the quantum which were estimated, or because of the lower diagnosis on the part of the pediatricians. Another question is that whether there is some data in children who were given TPT and who were not given TPT and their drug resistance pattern. Whether the TPT given in patients of the active TB can be a factor for the development of the drug resistance in children, to analyze that part.
Student answer, sir. Sir, 2-3 questions. One is BCG adenitis. Actually, according to guideline, no need to treat them. Nothing, no antibiotics, no isoniazid, and no treatment. So BCG adenitis has to be left at its own. It will occur subsequently. Number two, as you told, sir, regarding the that means whether the active tuberculosis guideline says that only sensitive child exposed to sensitive tuberculosis, because this is isolated prophylaxis, and in some other form also isolated plus rifampicin is there. So it is active only in case of exposure to sensitive tuberculosis. Once it is drug resistant tuberculosis, as you know, this isolated rifampicin must be registered. So there is no use of this. Second thing, whether use of this isoniazid as a prophylaxis will develop resistance. So to answer that question, whenever this preventive therapy is given, usually the vacillary remains in very silent phase, not very actively dividing. So chance of mutation is less, and various evidence is like that it has not caused more emerging resistance. So, and in resistance case, when exposed to resistance case, this is futile to give isoniazid. So depending on the culture sensitivity report to the index case, we may modify the preventive therapy. But obviously, isoniazid rifampicin won't be of much help.
So the question, whether there is a falling trend in the TB or we are underdiagnosing the TB in children.
Sir, to answer this question, I think I would say that we have still miles to go. I mean, the world data suggests that, they have shown 28%, but it's almost like 31% of the global caseload exists in our own country. And coming to the WHO data, I would say that although the incidence is increasing, and we all need to work together to increase the awareness. Under the NTP, we are still struggling at 6 to 7% notification in children as regards to NTP. So, I would say that each one of us, we need to have high index of suspicion and these awareness sessions, and we need to also have awareness, such models even in the different states, so that pediatricians they feel involved and we are able to diagnose and also notify. There have been instances where the notification is not being done and the diagnosis was made, treatment started. So notification until and unless notified, because it's a two-way process. Even the patient gets money, and the clinician also, gets benefits. Rather than the benefits, we are all working towards ending tuberculosis in our country, and we have all, I would say, we have controlled the tuberculosis. I would say that we have long ways to go before we can sleep.
Thank you.
So, yeah, Dr. Sangeeta.
Yes, sir.
Yeah, I'd like to just add on, just to talk to our ex-colleague from MIMSR. BCG test has got now a role. It is now an obsolete one. So we never practice it, don't advocate it, and it is not earlier. It was a teaching around 10 years back. We had been doing when we were junior consultants, but now last 10 years there's no role for BCG test in diagnosis of tuberculosis. Whether infant has been given BCG vaccine or not, that is a material.
Very important. I just missed that point because that was one of the questions asked. So no role of BCG, no role of ELISA. All these tests, these are obsolete now. I think Dr. Dhulika just checked.
So now I think it's time to wrap up this session. But before we close in, I would like to invite Dr. Ashok Bhardwaj, Chairman, National Task Force, for his closing remarks.
Oh, thank you, madam. So I thank the team NITRD Delhi, led by Dr. Sangeeta, Dr. others. So I must congratulate Dr. Atul Jindal, the professor and HOD of AIMS Raipur in pediatrics. So he is perhaps the only state task force chairperson from pediatric department who is heading in the state. So here I want to request Dr. Atul Jindal, because somehow we are still somewhere we are lacking in the pediatric TB guidelines. So I will request Dr. Atul Jindal, please take the responsibility of Chhattisgarh. Please train all Chhattisgarh pediatrician in the recent pediatric TB guidelines. So something Dr. Jackson told and Madam Sangeeta also answered it. But for us, for me, 1 in 5 pediatric TB case, though diagnosed but not notified. That is why we are getting less number of TB cases from the pediatrics TB cases. So it's not that the pediatric TB has been ended in the country. It's not that. So what we have to disseminate the guideline so that more and more TB cases are uh, presumed to be suffering from TB, then they are screened and diagnosed or otherwise for tuberculosis and started on treatment, and they are notified so that all benefits program which program is offering means nutritional support, then the direct benefit transferred, then Nikshay Mitra also, option of Nikshay Mitra also, then also for if it is the BMI is less than 2 months of the energy dense food along with the ATD medicine. So I will request Dr. Jindal, please take care of Chhattisgarh. I hope you will do it because AIMS Raipur is leading the state so that we can hope something that pediatrician, at least in Chhattisgarh, will be diagnosing more cases of pediatric TB. So thank you, Atul and your team for the case also interesting and informative case also, and the didactic information, the guidelines also. So these didactic lecture, I hope you will disseminate to the whole of pediatrician, all pediatrician in Chhattisgarh. So thank you, Sangeeta, for giving me a chance. Thank you, Dr. Yadav sir and Seemas. Thank you very much.
Thank you so much, sir. I would like to request all the audience to please attempt the post-test questions as well. We will meet again on 19th of August for the next TB Eco Clinic, which will be presented by the team of AIMS Bhopal. So see you then again on 19th of August for our next TB Eco Clinic. Goodbye till then.
Thank you.
Thank
you everyone for joining.
Thank you.